What it's not is not an extensive literature review or anything like that. It's really just a couple of conditions that I see commonly and the way I like to approach it. So this is a quick differential diagnosis for ulnar-sided wrist pain. So really, it can be skin, nerve, vascular, tumour, joint problems, tendon problems, and also bone problems. Again, I'm not going to go through all of these because we'd be here for days. So really, clinically, the history is probably the most important factor. Is it an acute onset? Is there an acute trauma? And usually for ulnar-sided injuries, it's often a rotational type problem or a rotational type injury. So the patient may be grasping or some sort of power grip and their hand gets forcibly rotated either into pronation or supination, or they'll have a fall onto the hypothenar part of the hand. So the hand gets hyperdorsiflexed and they'll have a hypothenar contact point at their point of injury. And so that's really the most common thing that I see in terms of the traumatic type ulnar-sided wrist pain. Then in the older age group, obviously you have your more degenerative type lesions. Just a quick video on the pisotriquetral joint. So I think it's a joint that's often forgotten. You sort of don't really think about it very much, but certainly you can see it, and it is a real joint. It does have cartilage on the end, and like all other joints, it can get arthritis and have problems in it. So don't forget some of the less known and less well represented joints. So clinically, it's a specific anatomic diagnosis, so you have to palpate all of those specific points. You have to palpate the ulnar styloid, you have to palpate the ECU, you have to palpate the distal radioulnar joint. Likewise, the TFCC and also the lunar-triquetral joints, and then depending on your examination findings, you have to stress those joints. And you need to try and duplicate the symptoms that the patient describes by putting the wrist in the position that they describe it occurs in. So the distal radioulnar joint, three or four of the most common problems. It's usually tended directly over the joint itself. Like any joint, you get a piano key sign, which is where you actually push about 4 centimetres proximal to the joint, and you'll see the joint may bounce up and down. And does it dislocate and reduce? And if it reduces, what position reduces it? And is the ulnar head prominent or is it sunken? And you can also squeeze proximal to the radioulnar joint radially and ulnarly, and you can get a axial load associated with the joint. Now, the distal radioulnar joint is also actually a weight-bearing joint when the forearm is in the neutral position and you're carrying things, so you increase your load across it. So don't forget that that's a good way of asking patients when they're loading the wrist if it's painful. Ulnar carpal abutment. So this is just an MRI of some ulnar carpal abutment. You can see the increased signal in the lunate, in the ulnar corner of the lunate, and this is commonly, but not always, in a ulnar positive variance situation. So the TFCC is something that I commonly see injured, and particularly in the younger age group. It's usually a discrete injury that's documented, and they get a painful click with motion, with pronation and supination, and can be tender over the dorsum of the TFCC, which is often the dorsal radioulnar ligament, or in the fovea. Now, the bottom picture here, which is out of the Journal of Hand Surgery, was the description of the foveal sign. So the foveal sign is described for TFCC tears where it's just distal to the tip of the styloid, just palmar to the ECU tendon, but before you get down to the FCU tendon. So it's a small spot, but if you push right in there, that's a pretty good indication that someone has a TFCC tear. I also am keen, I get the patient with their elbow resting on the table, and I put them in ulnar deviation and then extend and flex and rotate as I go. And often I'll feel a click in the side of the wrist as I'm doing that allows me to have a better indication as to whether that is causing their symptoms. And they'll often, as I'm twisting around, I'll feel a click and they'll go, oh, that's it. And in that situation, I'm pretty confident that I've got a TFCC injury, and I actually don't get any further tests after I do that. That's a pretty good indication for me that I think there's something going on there. Lunar-triquetral instability is the poor cousin of scapholunate instability. Everyone hears and knows about scapholunate, but the lunar-triquetral joint, I think, is often forgotten. Again, it's often an injury to the hyperextended wrist, and the patient has a sensation of instability and giving way of the wrist, and painful again on ulnar deviation, and they may feel a clunk in the wrist. Ballottement is basically pushing on the triquetrum and pushing it towards the lunate and trying to feel if it moves more than it should, and you can compare it to the other side. It's easy to compare to the opposite side. and then a shuck or a shear test where effectively you grab hold of the pisiform and the triquetrum with one hand and then stress it against the stabilized radial column of the wrist and move it backwards and forwards, much as if you were doing an anterior draw or something similar in the knee. A little graphic representation of that. And then mid-carpal instability, not a particularly well understood, and patients can often reproduce this and do this as a party trick. You'll see people make their wrist clunk. And this is very commonly on the other side as well. I find this rarely is a cause of symptoms, but there are a small number of patients who find this painful during activities. The ECU tendon, it can sublux around the ulnar side of the ulnar head, and patients can reproduce this for you, and that's a fairly clear diagnosis. And now ECU tendonitis, I think almost every ultrasound or MRI that I've ever seen, the report says there's some ECU tendonitis. I'm not convinced that this is necessarily the primary problem. The ECU subsheath on the, is on the dorsum of the TFCC, and I think that it's very frequent that when I scope somebody's wrist, I see ulnar-sided synovitis almost all the time. And I think that likewise you get some irritation of the ECU tendon and the ECU subsheath from structures deeper down. So radiologically, just plain films, a PA film to look at the ulnar variants in particular. And just for comparison purposes, we've got to try and make sure they're a PA film and that it's done properly. And what you're looking for on the ulnar side is the Gallula's arcs. So you want to make sure you have nice lines that run around the proximal part of the carpus and then in the mid-carpal joint as well. And special views, radial and ulnar deviation, and clenched fist views, and you're looking for a gapping or some sort of alteration in those lines. Looking at the moment, actually trying to work out a way of better diagnosing lunar-triquetral instability in particular with a stress view with grip and rotation. One of the guys out of Queensland has done some nice work on that and looking to try and validate that. I, for the most part, rely mostly on just plain films. I don't often get a CT scan. I sometimes get that for for degenerative conditions of the DRUJ to get a better look at the anatomy there in 3 dimensions. And MRI, I don't, probably like everyone else, a lot of patients come in with their MRI already, but I certainly don't send that many people off for an MRI for TFCC tears in particular, or for distal radial ulnar joint instability or lunar-triquetral ligament tears, because I think it's a clinical diagnosis. So an MRI, it's most often done for a TFCC. It needs a dedicated wrist coil. I don't think it should be the first study you order. It's expensive. It has a fairly high false negative rate, but the newer imaging 3T machines are better and they give you pretty amazing quality. But I certainly don't think it's an absolutely necessary test. I think arthroscopy remains the gold standard along with your clinical diagnosis. So this is what a TFCC tear looks like. That's a central tear. It's been debrided, but about 50% of the population over 50 will have an attritional tear of it anyway. It's pretty rare under 20 years of age. And really, I think the simplest way to think about it is like the meniscus in the knee. There's a central avascular portion and a peripheral vascular portion. So in that setting, you can't fix the ones that have no blood supply, so you chop it out, and the ones that have a blood supply you can fix, so go ahead and fix it. I generally perform a soft tissue procedure for those with TFCC tears without instability, and for those with instability, I think you need to repair it through the bone because I don't think it's strong enough to cope with it. So this is just a quick scope of the ulnar side of the wrist. So that's the TFCC down here. This is the triquetrum up there. There's some ulnar synovitis here. But effectively, what I'm trying to do is get underneath the TFCC to see if there's a peripheral tear. And really, there's nothing that pulls away. And the so-called trampoline test is where you actually push on the TFCC and push down on it and see how much spring there is in it. And that's a pretty normal-looking TFCC itself. So this is just a quick video of a central and a peripheral tear. So that's a TFCC. There's a central tear. So that's pulled away from the ulnar border of the radius just here. And that's the ulnar head underneath there. So that looks, that certainly can cause people symptoms. Now I'm on the dorsal part of the TFCC here, and I can get underneath that TFCC and lift it up. So that's been pulled away from the dorsal capsule. So like meniscal tears, this is a smaller version of a biter. Get in there and I usually bite away some of the unstable portion and then use a shaver and just shave it back to a stable rim to stop that flap floating around and getting stuck between the bones and causing impingement effectively. So for the peripheral ones, I that are not associated with instability. This is just an example of the suture technique. Basically, I make a longitudinal incision, which is approximately 2 centimetres long or so, over the ECU, and I do a repair through the ECU subsheath. And this is an outside-in repair, so I use a little, you can use a needle itself and 2 OPDS and run 2 or 3 sutures through the back there, and then basically tie it over the dorsal capsule. The main things to watch out for is that you don't grab your extensor digiti minimi by mistake, because it's pretty close to the ECU, and also the dorsal branch of the ulnar nerve. But I find that the dorsal branch is usually more distal, and I don't have to worry about that too much. So the other thing is the lunar-triquetral instability. It's pretty poorly seen on an MRI anyway. You see a step in the mid-carpal joint. There's a grading system for lunar-triquetral ligament tears, much the same as scapholunate ligament tears, which I won't go into. It's by Geisler. And effectively, what you're looking for is their abnormal movement or abnormal gapping between the bones. So this is the lunate here, and this is the triquetrum here, and there's a step from the lunate up to the triquetrum. These should be nice and smooth across there. And so you can also get a probe in there, and if I feel that if I can turn it sideways and I've got that instability, then that's enough to for me to think that their ulnar-sided pain could be coming from their lunar-triquetral instability. One thing I do see very frequently is in the setting of a TFCC tear, I often see a lunar-triquetral, at least membranous portion tear associated with it. I think that's the nature of the way the energy of the injury goes. It goes up through the lunar-triquetral ligament as well. So something I've been doing relatively recently is doing an arthroscopic lunar-triquetral stabilisation. The problem with the lunar-triquetral joint is that the reconstructive procedures are big and they take a long time to get better from. And also your other alternative, an arthrodesis, I'm not that keen on. So I've started doing basically a stabilisation of the ulnar carpal ligaments. So I'll debride between the ulnar lunate and the ulnar triquetral ligament, and then I'll place a suture just proximal to the triquetrum around arthroscopically from the fovea, which comes out about here, which is just on the border of the radius, and then I'll pass 2 sutures around that and tighten those 2 ligaments up. And when I do that, I also pass a K-wire across the lunar triquetral joint to stabilise it for about 6 weeks, which I then pull out just under local. And I've had pretty good success with doing that. I've reduced the mid-carpal joint with a probe and then pin it, and I've had pretty good success so far. I don't have any proper results for it as yet, but I've had pretty good success in improving people's ulnar-sided pain with this procedure. So in conclusion, history as always is most important, along with your clinical examination. Plain x-rays for the most, and that's usually accurate from my perspective, and you don't necessarily need any fancy imaging. So if your MRI findings are not consistent with the clinical ones, ignore the MRI, but sometimes you still look like a fool. Thank you.